Bismillahirrahmanirrahim. The quote for today is have more than you show, speak less than you know. Today, I am going to critically praise a GBD article using the weather checklist. I am Dr. Mohammed Awais, PGR of Community Medicine from King Edward Medical University, and I am giving this presentation under the kind supervision of Professor Saira Afzal. So, the gather checklist donates for guidelines for accurate and transparent health estimates reporting. The title of today's GBD article is The Burden of Chronic Respiratory Disease and Attributable Risk Factors in North Africa and Middle East. These are the findings from Global Burden of a Disease Study 2019. Here is the title of the article. Now, going towards its abstract, I am going to read its whole abstract. For clear understanding of the article, it is a systematic understanding of the distribution and trends. It is conducted because that systematic understanding and distribution of the trends are not available. They aim to report the trends of chronic respiratory diseases and attributable risk factors in the region, that is North Africa and Middle East, between 1990 to 2019. The methodology they utilized is they used the data from the Global Burden of Disease study, the 2019. Cause-specific mortality served as the basis for estimating incidence and disability adjusted life years, that is also called as daily. The burden attributed to risk factors was calculated by a comparative risk assessment, and contribution of population, aging, and growth was determined by the decomposition analysis. The number of deaths due to chronic respiratory disease in 2019 were 128,513 to 1,14,351. In 2019, the age standardized incidence rate of chronic respiratory disease was uh, 1,052 per 100,000 population and had a 10.3 increase, and the age standardized death rate was 36.1 with a 32.9% decrease compared to 1990. In 2019, United Arab Emirates had the highest age standardized incidence rate, and Afghanistan had the highest age standardized death rate. Chronic respiratory disease was responsible for 2.9% of total disability adjusted life years in 2019, that are mostly due to COPD, and second one is the asthma. With regard to the components of disability adjusted life years, the age standardized rate of years of life loss had a 39% decrease, while the age standardized rate of the years lived with disability had a 13.4% increase. Of total age standardized death rates due to CRDs is 31.61 were attributable to smoking, and 14.4% age standardized death rates are due to ambient particulate matter pollution. Their conclusion is that chronic respiratory disease remain a leading cause of death and disability in North Africa and Middle East, with growth in absolute numbers. COPD and asthma were the most common chronic respiratory disease, and smoking was a leading risk factor, especially in men. More attention is needed in order to reduce chronic respiratory disorders burden through appropriate intervention and policies. Here is the important text from the from the introduction of the article. In the North Africa and Middle East region, chronic respiratory diseases read from 12th cause of all ages death in 1990 to 6th cause of death in 2019, and it is responsible for 2.9% of total disability adjusted life years and 4.5% of total deaths in 2019. The previous studies have estimated the prevalence and burden of chronic respiratory disease and attributed risk factors at the global level, and showed that the prevalence of CRDs in North Africa and Middle East increased between 1990 to 2017 and was estimated to be 7.7% in 2017. However, the comprehensive data regarding the epidemiology and burden of chronic respiratory disease in the region is lacking. Thus, in this study, they provided a systematic report of chronic respiratory disease in the North Africa and Middle East region. They included the incidence, prevalence, mortality, disability life years, adjusted life year, and compared them by sex, age, countries, and socio-demographic index based on the global burden of diseases, injuries, and risk factor studies of the GBD study 2019. Now, coming towards the checklist, we have to identify 2 points in the objectives and funding. In the first checklist point is define the indicators, population, and time period for which estimates were made. Yeah, along this checklist, on the checklist, we have also have to mention the page number from which this information is given. So regarding the indicators, they have indicated that the incidence, prevalence, mortality, disability adjusted life years, years of life lost, and years lived with disability, they have going to conclude these findings. And the population that they have given is that the countries of North Africa and Middle East, they have given in detail in later on that there are 21 countries they have included in this study. And the time period they have given the time period of 1990 to 29. So this whole information is given on page number 2 and 3, and the list of funding sources for the work. They have given that they do not need funding for this as they have used the study the GBD 2019, and this information is also given on page number 11. Now coming towards the article, I'm going to read only the main highlighted points of the article that are the important points in the article. Going towards the materials and methods, the GBD study 2019 was conducted by the Institute of Health Metrics and Evaluation. It involves 21 geographical regions composed of 204 countries and territories from 1990 to 2019. It includes 21 countries that included Afghanistan, Algeria, Egypt, Iran, Saudi Arabia, Turkey, Palestine, UAE, and Yemen. As per GBD dictionary, chronic respiratory disease include the following five categories that are asthma, COPD, interstitial lung disease, and pulmonary sarcoidosis, pneumoconiosis that are caused by all the pneumoconiosis, that is asbestosis, pulmonary pneumoconiosis, and other pneumoconiosis, and other CRDs. They used the classification criteria for the classification of CRDs, that is International Classification of Diseases 10. The prevalence of disease CRD was estimated by the DIS-mode MR version using a Bayesian regression analytical tool. All cause mortality rates were derived from vital registration systems, census, and surveys. Cause of death ensemble model tool was used to generate CRD's mortality estimates. Code correct was used to ensure that the independently model single cause mortality estimates match the separately all cause mortality. Mortality to incidence ratios were applied to final CRD's mortality measures to estimate the incidence. To estimate years of life loss, uh, they have given the formula, and for years of lived with disability, they have also given the formula. A brief measure of the cost burden based on both the non-fatal health losses and premature deaths was reported as dailies, which were the addition of years of life lost and years lived with disability. Risk factor burden was estimated consistent with the general framework established for comparative risk assessment. This is the comparative risk assessment for calculating the risks. The risks that they have identified are 12, including behavior, environmental, occupational, and metabolic risk factors. Now, they also have classified the countries based on the socio-demographic index. And at the end, the decomposition analysis was conducted to analyze the contribution of population aging, population growth, and changes in the age-specific incidence rates on the absolute and chronic respiratory disease incidence. Data will be described in terms of absolute numbers and age standardized rates per 100,000 population following 95% uncertainty interval, 25th and 95th values of the ordered draws. Now, again, coming towards the checklist. In data inputs, it has 4 points. For all the data inputs from multiple sources, data synthesis is part of the study. In the first point, we have to describe how the data were identified and how the data were assessed. They have discussed briefly that the data were obtained from the Global Burden of Disease Study 2019 that is conducted by the Institute of Health Metrics and Evaluation. Next point is they have to specify the inclusion and exclusion criteria and identify all ad hoc exclusions. In this study, they have not directly specified the inclusion and exclusion criteria, though it references use that they have used the data of the GBD 2019 study. I'm going to clarify the ad hoc exclusions. It is the type of exclusion in which initially, based on the eligibility criteria, we include certain studies, but certain study surveys, but later on we excluded some of the studies that do not fit our study. So this is the ad hoc exclusion, which is not addressed in the study. Now going toward to the next point. The next point is to provide information on all the included data sources and their main characteristics. For each data source is used, report reference information or contact name, institution, population, representative, data collection method, years of data collection, sex and age range, diagnostic criteria, measurement method used, and sample size as relevant. The article has mentioned the data source that is from the Global Burden of Disease 2019 study that is conducted by the Institute of Health Metrics and Evaluation, where it does not provide a detailed reference or contact information for the specific data sources used. It has described the use of data collection that is from 1990 to 2019. It has involved both the genders that they have discussed later on in their tables, charts, and spreadsheet, but they have not given details for the age ranges. They have given the diagnostic criteria that they, for the chronic respiratory disease that they have used is ICD-10, and they have classified five respiratory diseases based on this, where they have not given any information regarding the sample size. The next point that we have to identify is to identify and describe any categories of input data that have potentially important biases based on characteristic listing item number 5. The article acknowledges potential data limitation due to gaps in vital registration systems in some countries which could introduce biases. That is discussed later on in the last portion of the discussion that they have bias may be originated because some countries that they have lack of data and registration systems that may include bias. The next point that we have to discuss is for data inputs and for data inputs that contribute to the analysis but were not sent as part of the study. And we have to describe and give sources for any other data inputs. The study primarily uses GBD study 19 and no additional extra sources were mentioned in the study. In the next point, we have to provide all data inputs in a file format which data can be effectively extracted. They have not given any permission or any kind of spreadsheet in their article from which the data can be extracted. Now, the data analysis portion. In the next point, we have to discuss provide a conceptual overview of the data analysis method or diagram will be helpful. They have given the information of the data analysis, but they have not given any diagram which may be helpful for this study. For example, on page number 3 and 4, the article provides an overview of the data analysis method, including using the cause of death, for which they using enzymal model. For the prevalence of chronic respiratory diseases was estimated by using the DIS-MODE MR version, a Bayesian regression analytical tool. Mode correct was used to ensure that the independently model single cause mortality estimates like the separately model all cause mortality. Mortality to incidence ratio was applied to final chronic respiratory disease mortality measures to estimate the incidence. Decomposition analysis was conducted to analyze the contribution of population aging, population growth, and changes in the age-specific incidence rates on the absolute change of the CRD incidence. Next, we have to provide a detailed description of all steps of the analysis, including mathematical formula. This description should cover as relevant data cleaning, data pre-processing, data adjustment, and weighing of data sources, and mathematical and statistical model. They have given this information on pages number 3 and 4, a detailed description of the analytical method, including statistical or like this mode, MR, and decomposition is provided. Furthermore, they have also given the calculation for years of life loss, years lived with disability, comparative risk assessment, and the socio-demographic index to classify the countries based on their socio-demographic rating. Next, The article makes a detailed explanation of how candidate models were evaluated or how the final models were selected. They also lay the information that there is no information on model performance evaluation or sensitivity analysis in the article. However, the article reports the uncertainty intervals for the estimates, which shows that the uncertainty was accounted for. I will show you later on the table, which they have shown the uncertainty intervals. And later on, the article does not provide information for to assess the statistical or analytical code used to generate the estimates. Now coming toward the results of this GBD article, first, the results are given for the incidence and prevalences. I'm only going a bird's eye view of the results to have a understanding of the results. The chronic respiratory disease incidence cases increased from uh, uh, 31 lakh to in 1919 to 58 lakh in 2019, revealing a 1.8-fold increase of CRDs. More, the age standardized incidence rate of chronic respiratory disease increased from 19,954 in 1919 to 1052 in 2019 per 100,000 population. Between 1990 to 2019, the age standardized incidence increased from in all countries except for four countries that are Bahrain, Iran, Iraq, and Yemen, and a decrease with a decrease in age standardized incidence rate. UAE had the highest age standardized incidence rate in 2019. Asthma had the highest age standardized incidence rate per 100 population, and pneumoconiosis had the lowest age standardized incidence rate. Age standardized incidence of pneumoconiosis decreased in men and increased in women. Now coming towards the results of the mortality, the number of chronic respiratory disease deaths in North Africa and Middle East increased from 78,174 to 128,523. And in 2019, COPD had the highest age-related death rate. The highest rate that was seen in 80 plus age groups. The number of chronic respiratory disease death increased in all standardized death SDI quartile during the study period, while the age standardized death rate decreased in all SDI. Disability life years and years lived with disability and years of life lost. In this, the North Africa and Middle East, the chronic respiratory disease were responsible for 2.9% of total disability life years in 2019. This is the table in which they showed the chronic respiratory disease burden by measure in 2019 with percentage rate by sex. In this, they have mentioned their burden, the gender, the incidence. They have also given the 95% uncertainty interval. They have also given the details regarding the time trend of all age number and age standardized death rate of chronic respiratory disease, the incidence, prevalence, death, and disability adjusted life years. They also have given the table for the age standardized burden of chronic respiratory disease in 2019 with percentage of age by sex. And they have also given a diagram for the North Africa and Middle East with the age standardized prevalence rate of CRDs in North Africa and Middle East countries in female and males in 1990 and 2019. The rate of chronic respiratory disease incidence, prevalence, deaths, disability rate, just like category by age groups and sex in 1919 to 2019. The trend term of all age numbers and age standardized rates of CRDs. Now I will read briefly the discussion portion of this article. In North Africa and Middle East, the age standardized incidence rate of chronic respiratory disease increased by 20.3%, and the age standardized disability years rate of chronic respiratory disease declined significantly by 26.5% between 1990 and 2019. This reduction was mainly caused by the reduction in age standardized death rate and age standardized years of life lost rate, while the age standardized rate of the years lived with disability increased significantly. These findings emphasize greater improvement in case fatality rather than changes in incidence and prevalence in the region. Age standardized incidence rate and age standardized mortality rate were the highest in were higher, while age standardized death rate and age standardized disability adjusted life year were the highest in low SDI countries. In the last portion of their discussion, they also have given their limitations. The limitation that they have discussed is where data are not available, auto sample prediction and imputation methods were employed by the GBD, and the results depend on effectiveness of these methods. Another limitation of this study is that they did not provide data regarding the incidence and prevalence of other chronic respiratory diseases, and thus they only reported mortality and disability adjusted life year. Also, there is a lack of standardized case definition across countries in order to distinguish different chronic respiratory disorders. Accurate diagnosis of some CRDs required special equipment such as spirometry, which may be lacking in less developed countries. Moreover, in some countries such as Africa, there is lack of functional vital registration systems. Additionally, the issue of confounder, especially between air pollution and smoking, has not been taken into account. Then coming towards the conclusion, in North Africa and Middle East, the number of incidents cases and deaths due to CRDs were increasing, and COPD and asthma were the most common CRDs in the region. Smoking was the leading risk factor for CRDs, especially in men. According to highest incidence and prevalence of CRDs in the region and the fact that much of the CRDs burden is preventable through the appropriate intervention policies. In this study, they try to provide more attention to on CRD as an important leading cause of death in the region. Now coming towards our checklist. They have not given any information in the results or discussion section. The published estimates are not provided in an acceptable format such as a spreadsheet, while they have report a quantitative measure of the uncertainty of the estimates that is given on tables, that is 95% uncertainty interval. They have interpreted results in the light of existing evidence. They have given many studies for justifications and for comparison, like the GBD studies and WHO global reports on chronic respiratory diseases. The article discusses limitations related to the data gaps, reliance on model estimates, and lack of vital registration models in some countries. This is the YouTube channel of our department where all the presentations of the residents are uploaded here. You can simply go there and see any presentation there. And thank you very much for today's class.
Thank you very much, Dr. West. Very nice presentation, especially that you have highlighted all the points in the manuscript while you are also presenting on the gathered checklist. So each checklist was completely supported by the evidence. And the most important point is that whenever we are doing any review of an article or we are doing critical appraisal, we have to be very inquisitive, and we should highlight the importance of the studies, strengths of the studies, weaknesses, along with the opportunities for other research that comes out of it. So, as I am also having SWOT analysis in my mind, your presentation fulfills all the important criteria. So, very well done, very good presentation, and I hope that this standard will be maintained. And in future, the articles published in New England Journal of Medicine, Lancet, and about the global burden of disease in any impact factor journal should be presented. Very nice presentation. Very well done. And you have maintained this good standard. Allah Hafiz.
Thank you, ma'am. Allah Hafiz.